Welcome, Brainiacs, to Brainista. I'm your host, Adrian, and today we're diving deep into the intriguing world of neurology and endocrinology. With me, as always, is the brilliant Anna, ready to unravel the mysteries of a condition that might sound like science fiction, Empty Sella Syndrome.
Thrilled to be here, Adrian. Always excited to tackle these fascinating and complex clinical challenges. To clarify right off the bat, the finding of empty sella is not that uncommon, being found in around 35% of the general population and clinically asymptomatic. Interestingly, it is more common in women by a factor of 4x or 5x. There seems to be an increased incidence of finding empty sella in conditions like idiopathic intracranial hypertension, but again, generally asymptomatic. But when the empty sella is associated with symptoms and/or signs originating from it, then we call it the empty sella syndrome. We will refer to it as ESS from here onward.
So, Anna, let's kick things off with a couple of compelling questions that I just know our listeners are pondering. First off, how can a structure in the brain literally appear empty on a scan? And what are the clinical dominoes that fall as a result? And second, with the rise in incidental imaging, how do we distinguish between a harmless finding and a condition that needs further attention?
Great questions, Adrian. ESS is definitely one of those conditions where the clinical picture can be surprisingly varied. And it's true, with more MRIs being ordered, we're seeing these empty cellas pop up more frequently. By the way, mid-sagittal MRI images are the best to visually screen the area of the sella turcica, its contents and surroundings.
Well, Anna, I am ready to immerse in the topic. Let's get to the heart of this and try to add some practical clinical utility for all our listeners. For everyone listening, we will be referencing a comprehensive review of Empty Sella and Empty Sella Syndrome, published in Endocrine Practice in 2024, and Empty Sella Syndrome, an update published in Pituitary in 2025. Links to the bibliography are in the description below.
All right, Adrian, so what exactly is empty sella syndrome? In a nutshell, it's a condition where the pituitary gland, which normally sits snugly in a bony structure called the sella turcica, appears flattened or shrunken on imaging. The flattening tends to be downwards, pointing at the flattening force from above it, generally thought to be arachnoid and CSF herniation into it. I guess we can say that there was a failure of the diaphragm of the sella, allowing for the downward herniation to occur.
Picture the sella turcica as a saddle and the pituitary as the rider.
We generally classify ESS into two types, primary and secondary. Primary ESS occurs when there's a defect in the sellar diaphragm. That's the membrane that covers the pituitary gland, allowing CSF to leak in. Secondary ESS, on the other hand, is caused by something else. A previous surgery, radiation, or even a pituitary tumor that has regressed and left an empty space. What's really crucial to remember is that the defining radiological finding here is that flattened pituitary, which can be seen quite clearly on an MRI. Again, easier to see in the mid-sagittal T2.
So, Anna, what are some of the things that cause this rider to be shrunken or the saddle to be filled with fluid? What key factors are at play here?
Excellent question, Adrian. Think of it as a combination of anatomical quirks and pressure dynamics. One major factor is that incomplete sellar diaphragm we mentioned earlier. If that membrane is weak or absent, CSF can seep in and compress the pituitary.
So it's like having a leaky roof that lets the rain in?
Precisely. Another significant player is chronic intracranial hypertension, such as an IIH.
So chronically elevated pressure in the brain, how does that tie into the empty sella?
Well, imagine squeezing a balloon. The pressure inside forces the contents to shift and redistribute. Similarly, in IIH, the increased pressure pushes CSF into the sella, flattening the pituitary. The etiology of the papilledema is probably not that different. And in the articles, obesity is an important factor, as increased central obesity is known to be associated with elevated intra-abdominal pressure, which leads to elevated cardiac filling pressure, increased venous pressure, and with that chronically increased intracranial pressure. We can't forget about pituitary factors either. Conditions like pregnancy or previous tumors can cause the pituitary to enlarge and then shrink, leaving behind an empty space that CSF happily fills.
So it's a multi-hit scenario. Weakness in the sellar diaphragm, chronically elevated pressure, and changes in pituitary size can all conspire to create empty sella syndrome. It's really like solving a medical mystery, isn't it? Anna, so we've got this empty saddle image in our heads. What are the actual signs and symptoms that doctors and nurses should be looking for? It can't just be a surprise finding on an MRI, right?
Exactly, Adrian. While many folks with an empty sella have absolutely zero symptoms, others present with a constellation of issues. The most common is headache, often persistent and lateral. Think of it as a constant reminder that something's not quite right in the brain's headquarters. The body is trying to tell you something. The headache in ESS tends to be dull or pressure-like rather than throbbing or sharp, and tends to be frontal, retroorbital, or in the vertex, but can be diffuse. It can be aggravated by bending forward, lying down, or standing. The headache can be from mild to severe. Dizziness is reported by 40% of patients.
So it's not just your average tension or migraneous headache. What else should raise a red flag?
For women, menstrual irregularities are a big one, anything from missed periods to abnormal bleeding patterns. Some women also experience galactorrhea or inappropriate milk production. even when they're not pregnant or breastfeeding. For example, I saw a patient once who thought she was going through early menopause, but it turned out to be ESS messing with her hormone balance.
So ESS can mimic other conditions?
Absolutely. And visual disturbances are another key manifestation. Because the pituitary sits so close to the optic nerves, increased pressure from the CSF can cause blurry vision, reduced visual acuity, or even double vision. In rare cases, cranial nerve palsies can occur, leading to impaired eye movements.
Okay, so headaches, hormonal havoc, and vision problems sounds like a real diagnostic challenge.
It is. But it's crucial to remember that the severity and combination of symptoms can vary wildly. Some individuals might only have subtle hormonal imbalances, while others experience debilitating headaches and significant visual impairment. That's why a thorough clinical evaluation is so important. You have to consider the whole picture.
This is all interesting, Anna. Once we've got a suspect, how do we confirm the diagnosis? Is it all about seeing this empty sella on a scan?
Seeing is definitely a big part of it, Adrian, but knowing is everything. MRI is the gold standard for visualizing the sella turcica. You're looking for that telltale sign of the pituitary gland flattened against the bottom of the sella, with CSF filling the space. It's like looking into a fishbowl and seeing the fish squished at the bottom.
Got it. So MRI gives us the picture, but what about the rest of the story?
That's where clinical and ophthalmological assessments come in. We need to check hormone levels to see if there are any pituitary deficiencies. Also, visual field testing to assess any optic nerve damage. A comprehensive assessment is key.
Are there any conditions that could masquerade as ESS? You mentioned pituitary tumors before.
Oh, absolutely. That is an important question. We must consider differential diagnoses. Things like hypophysitis, inflammation of the pituitary gland, or even arachnoid cysts. It's essential to rule out secondary causes. Sometimes these conditions can mimic ESS on imaging.
It sounds like a systematic, almost detective-like approach is needed.
Precisely. You need to rule out everything that can cause a similar picture to accurately diagnose. The key is, when something doesn't look right, you need to start digging deeper. If it looks like an empty sella, make sure nothing else is actually hiding behind it.
A diagnostic challenge for sure. What details are more important in your expert opinion?
First and foremost, get an MRI with and without contrast with thin cuts through the sella or pituitary protocol. Next, examine and understand the hormonal deficiencies. Third, get those ophthalmological tests.
So Anna, let's say we've diagnosed ESS. What does treatment look like? Is there a one-size-fits-all approach, or is it more nuanced?
It's definitely nuanced, Adrian. The treatment really depends on the individual's specific symptoms and hormone deficiencies. The foundation of ESS treatment is a personalized care approach, guided primarily by the presence of hormone deficiencies and the severity of IIH.
So it's like tailoring a suit to fit perfectly?
Exactly. If there are hormone deficiencies, hormone replacement therapy is the first step. The goal is to restore hormone levels to where they should be. If the patient has adrenal insufficiencies, we treat with steroids. Hypothyroidism is treated with thyroxine. Then we can treat the other hormone issues, if needed, with different treatments such as RHGH.
What about intracranial hypertension? How is that addressed?
Intracranial hypertension can be more challenging. Weight loss via dietary, medical, or surgical approaches is the first line of action here. But in some cases, we may need to use medications like acetazolamide, or in severe cases, even consider surgery like shunting or optic nerve decompression. It really depends on the severity of the symptoms and the individual patient. As far as I know, there is no medical or surgical procedure to decompress or shunt specifically only the sella.
Before we finish up, are there 3 key actionable points we can give our listeners about ESS treatment?
Absolutely. Here are 3 key clinically practical actionable points. First, prioritize hormone replacement based on individual deficiencies. Second, manage intracranial hypertension aggressively, starting with lifestyle changes. Third, consider first bariatric surgical interventions, less commonly CSF shunting, for severe cases unresponsive to medical management.
That makes a lot of sense.
For follow-up, it's crucial to monitor patients with ESS regularly, especially those on hormone replacement therapy or those who have undergone surgery. Remember that a multidisciplinary approach is key.
Absolutely fantastic. Now it's time to bring it all home. Let's turn this knowledge into action. Consider integrating the insights from today's episode into your clinical practice, particularly when evaluating patients with endocrine or neurological complaints. Remember, ESS often requires a collaborative approach, so don't hesitate to consult with your colleagues in neurology, ophthalmology, and neurosurgery to provide the best possible care for your patients. Thank you for joining us on Brainista today.
It was my pleasure to be here.
Disclaimer and bibliography in the description.